I think we'll go ahead and get started. We may have a few people who have come in late. This is our first talk this year for the Initiative for Individuals with Intellectual and Developmental Disabilities. This is our 5th year doing this at SPU. We usually have 3 speakers. I wanted to let you know that there is an outreach event in April 15th on autism. Autism Awareness Month is April. So we'll be sending out announcements about that. The initiative, one of the goals of the initiative is really to educate our SPU community and larger community about disabilities. So the speaker series has been an excellent way to do that. Let me tell you a little bit about Dr. Chen. Maida Chen is an MD. She's an associate professor of pediatrics at the University of Washington School of Medicine and the director of the sleep disorders clinic at Children's Hospital. She earned her medical degree at Northwestern University and completed her residency in pediatrics at Rush Presbyterian St. Luke's Medical Center. She also completed a pediatric pulmonary fellowship at Children's Hospital in Los Angeles with a special focus on respiratory control and sleep medicine. Her research and clinical work focuses on individuals, especially children with special needs, including those with fetal alcohol spectrum disorders, hindbrain malformations, and autism spectrum disorders. I think this is the 2nd time she's been a speaker for the initiative. The first time was in 2012, when she really focused on kids. So this is the first time we've been able to hear her talk about adolescence, which we know is a really important period of development. So join me in welcoming Dr. Chen.
Okay, so I am technology challenged at times. Anyway, thank you all for being here tonight. I have a few disclosures, none of which will conflict with the content of this presentation. And what I'd really like to talk about tonight is sorry, I think I'm feeding back a little bit, a multifaceted approach to the diagnosis, management, and referral of sleep challenges in adolescents across the developmental spectrum. I'm going to focus primarily on typically developing adolescents, just because I think that we all forget when we are dealing with individuals who have differences in their development and in their intellect, that they are still adolescent in terms of body and their age. And so I want to really review some of the basics of that. We're going to talk about delayed sleep phase syndrome, insomnia. We're going to talk about poor sleep hygiene, which really comes down to media use as I stare at a sea of MacBooks out there. We'll highlight examples of these disorders in those who have FASD, autism spectrum disorders, and ADHD. Each one of those disorders in and of itself is a whole dissertation, and so I'm not going to go into too much detail. There's just not enough time, and focusing a little bit more on the typically developing. But certainly if you guys have any questions along the way with patients or clients that you've seen, please do raise your hand and ask. I'd love for this to be interactive. So, just in terms of background, and at this point, okay, if every kid got an ideal amount and quality of sleep, you'd maximize their developmental potential and you'd optimize their overall health. And you'd end up with happy toddlers and preschoolers and elementary school kids and high schoolers. But what happens when a child does not get that ideal amount or quality of sleep? And so I want to just keep this sort of rubric in mind, where if you have improving outcomes over time, which is just a hypothetical trajectory of any outcome, pick anything, whether it be something physical, mental, anything like that, and you expose that child to a sleep disturbance, potentially treatment, potentially not, do they recover to the point of meeting their old trajectory? Do they take a delay? Or do they take a permanent deficit or a permanent hit, so to speak? And there's more and more evidence that the children who are exposed to significant sleep disturbances early in life take on more of a deficit with time. So, sleep problems in children. For those of you who are not parents in this room, this is a little bit of a different concept, but typically when you go to the doctor, you say, I think I have a problem. They may or may not run some tests and then say, you do or do not have this problem. It's different in pediatrics, and this includes teenagers. When that parent comes in and says, my child has a sleep problem, by definition, there's your diagnosis. There is a sleep problem. Whether or not you can prove that sleep problem with anything objective, a blood test, a sleep study, or anything else like that, is inconsequential. There is a parental perception that there's a sleep problem, and that needs to be addressed. And we know sleep problems are really common in childhood, and there's not a whole lot of prevalence data on adolescent sleep problems, but it's fairly similar in the sense that we know likely up to 70% of adolescents will have a sleep problem at some point during the week, whether it be acute insomnia, insufficient sleep, and it's probably more rampant than that. And 30% likely it's kind of in that chronic condition where it happens habitually over months and months. We also know sleep problems with a wide variety of definitions are more common in children who have special needs. And you can see some of the prevalence rates there, but I mean, this is basically everybody. So if you have children in your practice or teenagers who have autism or FASD or ADHD, you have to know about their sleep problems because really it's a ubiquitous finding in these populations, and it is completely pervasive in how that parent and family function. So every subspecialty has its categorizations of sleep problems, and these are ours. And this is really just here for your reference. And we're going to be talking primarily about the insomnias and the circadian rhythm sleep-wake disorders tonight, because those are the two most common ones that we're going to encounter in adolescence. Specifically about individuals with special needs, in the big picture, we have very little evidence. The most probably exists in those with autism, but really beyond that, we don't have a whole lot out there. For instance, with the fetal alcohol spectrum disorders, there's like a whopping 3 papers. I've written one of them, and hence I'm a world expert. Yeah, it doesn't really get a whole lot more easy in some ways from an academic standpoint, but certainly there's just not a whole lot out there when it comes to individuals with special needs and their sleep problems. But we do know that it's a huge impact on family, caregivers, and the actual child or individual. My goals of treatment when I work with families who have an individual in their family who's got developmental differences is I want to optimize that individual's health, function, and quality of life, but it is equally important to me to optimize that family and the caregiver specifically's function, quality, and health. Because really that individual, the individual with the developmental difference, cannot reach their neurodevelopmental outcome if their primary caregiver is sleep deprived. Just think of it that way. You can try all you want in somebody who has, let's say, FASD, but if their primary caregiver, let's say mom, if mom is so sleep deprived she can't think straight at all or gets in a car crash because she's so drowsy, it's sort of game over for that kid. So we really need the caregivers, and I think parents and caregivers definitely, we need to learn a lot more about their sleep as well. Predisposing conditions in children who have with developmental differences and sleep conditions. So the first one is behavioral conditioning. And a lot of it is that if you have a child who's got a lot of medical complexities, a lot of times early in life, those parents will make special exceptions in the sense of we'll let that kid sleep in the room or always hold the child or something like that. And regardless of that child's developmental ability, that child will likely learn, well, this is the only place I can sleep. Mommy's arms. And so there's behavioral conditioning in that sense. We also know in general intellectual disability is likely linked with sleep problems, and it's probably due to lack of ability to effectively communicate, but it's not always. Epilepsy, which is obviously prevalent in these conditions, visual impairment, not getting your light cues from the environment, motor impairment, inability to maintain, say, your airway while you're sleeping at nighttime. You could certainly have an obstructive apneic event. But for all of these kids with all of these different conditions, they go through puberty and they become adolescents. And they may not developmentally match that, but their bodies will go through it. And so there are just some fundamental physiologic things that we need to know. So how do we assess sleep problems? So if you guys can read this cartoon from afar, it says, we want you to relax, get a good night's sleep, and we'll evaluate any sleep issues that you have. And this is kind of what a sleep study looks like. We'll talk a little bit more about that. How I break it down, when you come and see me in clinic, I have the luxury of a full hour with patients, which is unique in medicine. And I sit down and really go through a day in the life of little Johnny. And if you want to look at it broadly, the things that I focus on are quantity, so just the hours per day, the quality of sleep, and I look for both endogenous sleep disorders as well as exogenous disruptions to sleep. I also look for states of hyperarousal. I mentioned this in specific because anxiety is such a common comorbid condition in almost all people who have developmental differences, again, stemming from that ineffective communication at times. And then I look at timing. So maybe you have no problem sleeping if school started at midnight. And if you got to sleep all day, maybe you wouldn't have a problem at all. It's just that unfortunately that timing, when it does not align with societal expectations, becomes an issue. How to assess them? So there are questionnaires out there. The pros of questionnaires, obviously, you can query across all those domains of sleep. You can ask how long they're sleeping. You can ask if anything is going bump in the night. And you can ask if they are napping and things like that over the weekend. They're inexpensive and they're relatively quick. The problem is that they are rarely validated in a clinical setting, and they're almost always used for research studies. And the other thing is in order to answer a questionnaire, people don't know what they do themselves in their sleep. They're dependent on somebody observing them. So really, if it's a parent, it means you're watching your kid. If it's a bed partner, it means you're up and knowing what your partner is doing. But in a lot of instances, teens are not really sleeping with anybody else. And so our teenagers in specific, this becomes a very poor instrument. There are some self-reports for teens. They are rarely validated in special needs populations, but interestingly, and I'm sure most of you have experienced this, if you give a teen a survey, that teen is more likely to be honest and fully disclosed in that anonymous survey than they are with parents or any sort of provider. So in that sense, self-report can be beneficial, but again, rarely validated in special needs populations. Other things that we commonly do are sleep diaries. So sleep diaries are very elementary, and there are electronic versions. I tend to still do paper and pen because I'm old. But it forces the individuals or caregivers really just to observe and record. That's all I want you to do. And basically figure out the times that you're sleeping, that you're awake, that you're sleeping again. And it's almost always diagnostic for circadian problems, insomnias, or insufficient sleep. And we use it to track success over time with treatment. This is an example of a sleep diary where this child has delayed sleep phase. We'll talk a little bit more about that. Delayed sleep phase is where, again, your inherent sleep timing is later than what society wants it to be. And so this kid is somebody who's in high school, and if you recall, high school, you need to be up somewhere around here. And clearly this kid is not able to fall asleep despite efforts of going to bed until after midnight and then sleeping until 10 or 11. I was seeing this child because this child was essentially kicked out of school for being a truant, for never getting to school. And really, if this kid had a start time of noon, would probably be okay, but unfortunately high school started there. A fancy sleep diary is something called actigraphy. So actigraphy is really just an accelerometer. It measures motion. And basically it assumes that if you're moving at a certain rate, that you are awake. If you are not moving at a certain rate, that's detected on your wrist usually, that you are asleep. It's not perfect. It is better in a research setting than it is a clinical setting. And it's basically the technology that the latest trends with Fitbits, iPhone, whatever tracker, I'm wearing one, except my battery's dead. But it's similar technology. The actigraphs that are used in research settings are way more sensitive than the Fitbit technology, just for those of you who are thinking, oh, well, why would we pay X amount for Actigraph, which that thing costs about $900, when a regular Fitbit will cost, what, I don't know, 80, 120 or something like that. The technology to the research grade Actigraph is much more sensitive, and you'll get much more detailed information than you will off a Fitbit accelerometer, but it's definitely revolutionized the way that we've been able to capture data in the home setting. Circadian assessments. So if you remember your circadian rhythm from biology, we have two major things that are dictated by our circadian rhythms. One is melatonin release, and the other one is body temperature here in blue. And as we go to sleep, our body temperature drops, hence cold and sleepy, and our melatonin surges, which is what signals our brain primarily to fall asleep. And you would think that there'd be an easy way to measure both of those in order to get circadian rhythm. Well, from a temperature standpoint, this is core temperature. So it's not something that you can get really under your tongue. This is usually a rectal probe or an intestinal capsule that you swallow. Not easy. And not really well loved by a lot of people, as you can imagine. And then for melatonin, it's not something that you can get all that easily either. So melatonin spikes in the dark. So in a research setting or even a clinical setting, if you bring a patient into clinic and say, well, let me measure your melatonin, it's light out. You're not going to capture it in either their saliva or their blood. So to measure melatonin successfully, you need to actually have these people in a dark setting. And when I mean dark setting, I mean dark setting. And we will, in research experiments, part of my costs for my research is paying somebody to go to somebody's house, putting blackout shades on all the windows, unscrewing all the light bulbs, and basically measuring the lux in a certain room and keeping that kid in that room for 6 hours while we measure their melatonin. It is very cumbersome, not easy to do. Okay, and then ultimately we have a sleep study. So sleep studies were designed primarily to look for breathing disorders, obstructive sleep apnea, but they do measure brain activity and body activity, as I tell families about it. We look at encephalograms, oculograms, myograms, cardiograms. We look at airflow, snore, oxygen levels, carbon dioxide levels, thoracic and abdominal movements, and then we video record the whole thing. It is like that cartoon at the beginning where in an adult lab, then the adult is just said go to sleep, and that's it. In a pediatric lab, we obviously go through a lot more, and the kids have a great time. I mean, we think that they're going on spaceships, they're searching for Nemo, they're doing all sorts of things. They get little prizes, stickers for every little thing that's put on them, and we never have to medicate our kids in order to get them to go to sleep. And we have a very low fail rate in terms of whatever kid comes in, we usually can do. And just for an example, this kid is somebody who is being evaluated for ADHD. Normally can't sit still, can't do anything at all, but he was able to tolerate everything. This infant, her mom had a 12-pack of beer and a 5th of vodka every day through pregnancy. And she was able to tolerate this well as and she was adorable and managed to do okay. For our kids who have particularly sensory difficulties, we will send home kits when we see them in clinic first with practice cannulas and practice stickers and practice leads. And there's a brochure and there's also a CD, and now we put it on jump drives, and we give it to our families and say, this is what it's gonna look like. Practice with the leads, put them on and things like that. Our child life specialists will also work with families, particularly children who have severe autism and severe sensory integration disorders, on getting them to tolerate these leads if we really feel like obstructive sleep apnea is something we need to rule out. And then this is actually a typically developing child, and Bev, this is my daughter. And this is my daughter. She was one of the first research subjects that I did, and this is why researchers have children, so they can be the normal controls. But my point in showing this slide is that, you know, we did the least amount of preparation for her. Out of everybody, she failed the worst. But we managed to still be able to get data on her. So even the kids who just go ballistic during the sit-up, we are able, once they calm down and once we work with them, we're able to get the information that we need. So one day she's going to hate me for throwing her under the bus in like every lecture I give. Other things that we do to objectively look at people when we're talking about sleep. This is a fascinating test, multiple sleep latency test, or MSLT. And this is basically something that objectively quantifies sleepiness. Now, sleepiness and fatigue, tired, you know, they get confused a lot in terms of that terminology. I'm talking about a biologic propensity to fall asleep. So I bring you into the sleep lab, you spend the night with me. Then the next day, at every 2-hour intervals, in a dark room, I say, lie down, close your eyes, and try to go to sleep. Sounds delightful, actually, in terms of those opportunities to nap. But we know that somebody who is well slept will not actually sleep during those naps. Maybe one nap, like right around after lunchtime, but you're not supposed to fall asleep during those times. And we know people, for example, with narcolepsy, medical residents, things like that. They fall asleep in all of these naps, and they'll fall asleep in each nap less than 5 minutes. And that's really worrisome because that is abnormal levels of sleepiness. But that helps us to quantify sort of that degree of sleepiness. The opposite test is a maintenance of wakefulness test, and this is something that Air Force pilots have to go through, all FAA pilots, all truck drivers that do long distance, and this is the ability to stay awake. So just the opposite, where at every 2-hour intervals, it's a 20-minute opportunity where you're sitting there in the dark looking at literally nothing, which is supposed to mimic a boring freeway or the sky or something like that. And you just sit there and we basically have leads on you and we can see whether or not you're awake. And obviously this is a vigilance test in the sense that if you are a long distance truck driver or a pilot or something like that, you're staring at very boring visuals for a long period of time. We don't want you falling asleep. So this is another test where we can say, oftentimes for people who are on treatment, stimulant treatment, to say, oh, well, is it really working or are you still sleepy? Okay, so that finishes up our assessment and the tools that I have in my bag to help figure out a child's sleep problems or a teen's sleep problems. But let's go on to sort of a case presentation, which will then guide the rest of our discussion. So primary complaint is my teenager is always fatigued from a mom. This is a 16-year-old male who's otherwise healthy, was a solid B student in school until this last year, when grades started falling, and he started getting in trouble at school for defiant behavior. He usually has dinner at 7 or 8 p.m. It's usually after soccer practices and games, and he's most awake at 9 or 10 o'clock at night. That's one question I always ask teenagers. What's the time that you are most awake? He's not done with homework until 11, and he really does. He's a good kid. He tries to go to sleep at that point in time, but he's just not sleepy until 1. So he's lying there in bed from 11 until 1. He's frustrated that he can't sleep. He thinks about how tired he's going to be. So what does he do? He busts out the smartphone. He needs to be up at 6 o'clock for school. He'll sleep in until noon or 1 on weekends if he's allowed. He's frequently tardy. He sleeps through his first few periods. Both of his parents work, and he drinks coffee or energy drinks in the morning and increasingly in the afternoon, and very scary, he admits to occasionally falling asleep at the wheel. So let's just chart what we would love for ideal adolescents to be. So if we have increasing amounts of sleepiness here and time over here, we would love it if they were awake with minimal sleepiness. Right at 10 p.m., bam, they're just asleep. And they just go to sleep and they stay asleep, and then right when they need to wake up at 6 a.m., they're up. And they're totally alert throughout the day. And so we would like that to be the repeated, and really the paradigm of sleep medicine is sort of based on this very unrealistic model. This never happens in real life. In reality, and I'm even putting reality in quotes because this isn't totally reality, but at least the timing is a little bit better, for our patient, he's not asleep or sleepy even until 1 o'clock in the morning. At best, he's starting to become alert at 9, but he told us on weekends it was closer to noon. And so you can see that this shift is a misalignment between his body rhythm and society's rhythm. So he goes through this process where he's so awake. He told us he was most awake between 9 and 10 o'clock at night, right at the time that, his mom is yelling at him to go to sleep. Then he can't fall asleep. So he medias. Then he can't wake up. And then he is so tired during the day. Okay, does this pattern sound familiar to anybody? All right, you guys are not living up to it yet. Okay, but the pattern just repeats in terms of what we have here. And so this misalignment between wake times and sleep times is really the crux of delayed sleep phase syndrome. So we all have circadian rhythms. We have an inherent biologic pattern that includes sleep, wake, hormones, temperature, basically everything. And really the driver of this is melatonin. So in a couple of slides ago, we saw a brief glance of it, but basically your pineal gland starts producing melatonin in the early evening hours. In younger kids, probably around 8 o'clock at night. In adolescents, probably closer to 10 o'clock at night. Within an hour or two of that, you basically are supposed to be falling asleep. So right here where this curve inflects, and then it surges after you fall asleep. In people who have delayed sleep phase syndrome, really it's that misalignment, and it's an intractable phase delay that conflicts with societal environmental expectations. By definition, if this child lived on an isolated island or school started at 2 p.m., he wouldn't have delayed sleep phase syndrome. So it's a timing problem, not a sleep problem per se. And it results in that daytime dysfunction, that I'm so tired, and really it's because their melatonin, and we've seen this in study after study in both humans and animals across basically the animal kingdom, is that when animals go through puberty, they have a delay in this melatonin surge. It happens across. And so when you have somebody who might not be able to speak to you or has huge sensory issues, if they're fighting sleep or really having trouble with sleep early, then think, well, is this person beginning to go through puberty? I also have to remind you guys just about the whole puberty thing. This is something that starts at the beginning of puberty, and in most kids we start seeing this in the immediate pre-pubertal phases. Puberty is something that we used to think happened when, you know, girls were around 12, 13, boys around 14, 15, but it is not uncommon now to see girls start puberty at around age 9, which means that you can start seeing this shift at age 8. I have an 8-year-old daughter who's in 3rd grade. It seems ridiculous. But really, the age of puberty going down and down and down is something that you need to consider, because basically they may be an 8-year-old mentality but trapped in a 13-year-old's body, and you have to know some of the physiology that occurs with physical puberty. It naturally improves in the 20s, but for some people, especially the 15% who have pretty severe delayed sleep phase, this is when that pattern is solidified, and they basically become night owls for life. There is a very strong genetic predisposition. If you have a parent who's a night owl, the likelihood of you becoming a night owl is strong. The likelihood that you were a relative night owl as a younger child is also usually very prevalent in people who end up with more intractable phase delay. There's clearly a hormonal shift. We don't know the mechanisms completely, but there are a couple of things that contribute to this. And again, this comes up a lot in kids who have intellectual differences and developmental differences, in that as you get older, so when you're a 2 or a 3-year-old, you have what is called sleep pressure that builds up very quickly. They need to nap in the afternoon. As you get older, your sleep pressure builds slower over time, such that you can get through the day without a nap, or at least at this age, you guys are supposed to be able to get through the day without a nap. And that's one thing that happens in adolescence, is that this whole new concept of being able to stay awake longer, adolescents can always stay awake longer. Always, always, always. And so if you give the adolescent an opportunity to go to sleep earlier, not only will they not from a societal standpoint and a behavioral standpoint, they can't from a physiologic standpoint. So keep that in mind. Binge sleep on weekends. This is where, you know, you have the teenager who's like not waking up until 1 or 2 o'clock in the morning. And parents have this urge to say, let a sleeping child just sleep. And really, binge sleep on weekends is about the worst thing that you can do for a teenager. So that teen has now woken up at 1 or 2 o'clock in the afternoon on, say, Saturday morning, Saturday afternoon. That night, they're not going to be able to go to sleep until at least 1 or 2 in the morning. Sunday, 1 or 2 in the afternoon. Sunday night, they're not going to be able to fall asleep until 1 or 2 o'clock in the morning. But then come Monday morning, they need to be up at 6 a.m. And so they're really shortchanging themselves as they go into it. And binge sleep, we know, because circadian rhythms are driven most by what time you wake up. Not what time you go to sleep, but what time you wake up. So if you allow that child to wake up at 1 or 2 in the afternoon, that kid's pattern is set until it's broken again. And just a reminder that teens need about 9 hours of sleep. And most teens think that because they're kind of closer to adults in size and what their bodies look like, oh, we can get away with 7 hours. They don't. Any teen who chronically sleeps 7 hours will binge sleep on weekends for you. So really the goal is to try to get them closer to at least 8. Okay, so we've gone through this whole hormonal thing and the melatonin thing, and that dictates stuff that happens. But what happens if your melatonin doesn't look like those curves? And there are a couple of conditions where that happens, and fetal alcohol has recently been studied. And again, here's a reminder of that, what typical teen distribution of melatonin looks like, where it surges right at that beginning of the night hour. But then this is a study, looked at a very small sample, I think it was like 25 kids, and they put them in a lab setting, darkened the rooms, and basically looked at their salivary melatonin over the night, and you can see that the smallest group had something that maybe looks like that, but none of these curves look like that. And so one of the most prevalent complaints in kids who have fetal alcohol is that they can't sleep. And maybe their inability to sleep is really that they don't have melatonin. So do we give them melatonin? Most of them are on it at some point in time. It's a question to be answered. Looking at behavioral sleep-wake rhythms in adults with autism spectrum disorder, importantly, these do not have comorbid intellectual disabilities, but by both Actigraph and sleep diaries, close to half of the adults had a circadian disorder in autism. And the majority of them were delayed, meaning that they just would go to sleep later and wake up later if they could. And knowing what sleep deprivation looks like in adults, it may be very much so contributing to the phenotype that they're being treated for. So important considerations to know that if you have somebody who has a developmental difference, that maybe their brains don't make melatonin or don't respond to melatonin in the same way. So back to our tired teen. This was hilarious. And the things that you can find on Google Image. Okay, so ticked off, irritated, ready to cry, extremely upset, and just done. And that is what a sleep-deprived person looks like at a lot of levels. So let's talk about sort of what I'm so tired looks like in a teenager. That daytime dysfunction. So a couple of caveats, and I put these in almost all my lectures. The first and foremost is that parents are not accurate or knowledgeable historians, especially in teens. I can't tell you how many times I've had parent and teen in a room, and parent is just like, no, really, they go to sleep at 10, lights are off, blah, 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 blah. I kick the parents out, and the teenager's like, maybe 3 o'clock in the morning? Maybe. And I'm like, oh, yeah, anyway. And it goes sort of both extremes. So teenagers don't typically sleep with their parents, but the teenagers who do sleep with their parents, for whatever reason, usually that parent sleep is so disrupted that that parent is also a very terrible reporter in and of itself. This is also an important point. Fatigue does not equal sleepiness. They can overlap, and they can overlap significantly, but sleepiness is the biologic propensity to fall asleep if given the opportunity. Fatigue is a behavioral state of mind. So when patients come into me and say, I'm so tired, I really sit there and I try to figure out, well, what does that mean? Are you sleepy or are you fatigued? Because those who are fatigued, who have low energy and really more of a behavioral state, if given the opportunity, will not sleep. And that is typical for those who have classic insomnia. So people with insomnia, they're in bed, the lights are off, they have nothing else to do, but they can't fall asleep. So that's a state of fatigue and not sleepiness. Whereas if you take somebody who is a narcoleptic, or if any of you who are normally well slept pull an all-nighter, you're sleepy the next day, where if you lie down, you're out. In younger children, and I put this up here because even though we're focusing on teens, remember what I just said about puberty, it can start as early as 8 in girls, and so really they're going to fall into this younger category in terms of psychologic development. But their manifestations of bad sleep, whether it be lack of sleep or disrupted sleep, really are these first and foremost. Poorer academic performance, more inattention, hyperactivity, impulsivity, mood and emotional ability, and they rarely have overt sleepiness. If you have a pre-pubertal child in front of you who is saying that they're falling asleep in school, somebody has missed the boat somewhere, like in a big way. In adolescence, the important thing to know is that all of these happen first, and then they get sleepy. The other things that they will have are erratic moods and judgment. There are some great epi studies out there looking at adolescent report of risky behavior and correlating that with objective amounts of sleep. And there's a clear correlation. The less sleep an adolescent gets, the more risky behavior when it comes to kind of the sex, drugs, rock and roll thing. But it's completely lines like this. They have school attendance issues. They more commonly have overt sleepiness, and where we get into trouble is they start medicating more. I call it the Starbucks sign. When a teenager comes into my clinic with the, venti mocha with like 8 layers of whipped cream on top, and they're like, I don't know why I can't sleep at night. I'm like, really? Really? Let's start with the basics. But all those things in that, all those phenotypic characteristics I just described match what we define as ADHD. So we know that, and that is really one of my most common referrals, is a child or a teenager who's come in and said, my teacher thinks, my parents think I think that I may have ADHD, and somebody is saying, well, maybe we should explore your sleep a little bit more. This is an excellent review, and I would encourage all of you to read it if you have the opportunity. It's long, I can't get into all of the results here, but it's looking at sleep disturbances in teens with ADHD. And it's really a very well done and comprehensive review. Great place to steal citations for any sort of report. But the sort of take-home points is that the prevalence of ADHD is 8%. I suspect that's, I don't even know what that number means. It's probably much higher in circles if you, depending on how you define ADHD. True prevalence may very well be lower as well. But we know sleep complaints are present in about half of these kids at any point in time. But pediatricians tend not to ask about the sleep in ADHD because they frankly don't know what to do about it. Comorbidities that are very common, and there are a lot of people who think anxiety is simply on the spectrum of ADHD, but oppositional defiant disorder, conduct disorders, mood, anxiety, learning disorders, and intellectual disability all will confound and most commonly worsen the sleep complaints that are found in ADHD. Another consideration in those with ADHD is stimulant medications. A lot of kids with ADHD not only self-medicate but have prescription medications that are stimulants that we know frankly interfere with sleep. And so if you have somebody that you're titrating daytime symptoms and you give them more and more and more stimulants during the day, and all that it's doing is preventing them from sleeping at night, worsening their symptoms the next day, you can see how it gets into a bit of a vicious cycle in terms of that stimulant usage. Not to say that there's not a role for stimulants in ADHD treatment. So how do we treat? I'm going to go back to the delayed sleep phase for a second. And this goes for kids across the developmental spectrum, and I really want to hammer this in here. What we can do about this sort of misalignment of circadian biology in teenagers and society. So treatment A is just generally change the kid or change the biology. This is really hard. We suck at this in general. This is like my worst outcomes in sleep clinic because it never works. Significant family support is needed. Essentially, it's a full-time parental job devoted to the phase shifting if you really want to change that kid's circadian biology. I mean, just take any teenager, move them to Hawaii where they should be early risers, and within a day, they're right back to being light sleepers again. There's really 3 flavors that treatment A can come in, but all require no daytime naps, no caffeine, full parental supervision, and a strict commitment to wake and sleep times. And there's a high relapse back. So let's go through these 3 flavors. This is flavor number 1. So if you have somebody who is typically falling asleep at 1:30 in the morning and waking at 10, you just basically say, we're going to make bedtime 15 minutes earlier and wake you up 15 minutes earlier every day. Seems simple enough. And that is the advice that most pediatricians will give, and frankly, most grandmothers give too. Where we get stuck is really, this is this kid's biologic sleep time. And basically, they get stuck here, and then they can't advance any earlier. I mean, if it were that simple, a kid who falls asleep at 1 o'clock in the morning, I'd say, well, tomorrow go to sleep at 12:50, the next day go to sleep at 12:40, and they can't do it. They're just not sleepy prior to that point. And you can see that this is not compatible with any sort of school attendance, at least not in the morning. So this is really something where a parent needs to miss work. But they get stuck. They get stuck here and they can't advance any further. So that's not going to work. Second option is a little bit more real life in the sense that if you know that your goal is at 6:30 in the morning, you start by letting them go to sleep at their bedtime at 1:30 in the morning and say, no matter what, I'm waking you up at 6:30 every single day. So that means the first night they're getting, 5 hours of sleep, the next night a little bit more, the next night a little bit more. And in theory, if you don't let them nap anywhere or crash anywhere in here, then you'll just advance them to the point where then you can maintain the 6:30 wake time. The theoretical is that the sleep deprivation builds up and it drives earlier sleep times, but on paper it's more compatible with working parents because if the parents need to be out the door at 7, at least the kid is up. But what happens is it works for about 2 to 3 days, and then on day 3 or 4 the kid crashes and takes a nap here after sleeping 5 hours, and then they fall asleep from 3 p.m. to like 9 p.m. and they're absolutely screwed because then you're just right back there. So that's basically what happens, is that the kid fails after usually about the 3rd day. I'm seeing a lot of nodding heads. Okay. This is the third option, which is just absolutely just horrific in theory, but it is actually biologically the most plausible. Remember what I said? Teenagers will always stay awake later. So this is where you march their bedtimes around the clock the other way. So if their normal bedtime is at 1:30, you say, guess what? You get to stay up until 4:30. How excited is that teenager? They get to do anything they want until 4:30, minus media, but you know. So they get to stay up until 4:30. They get to wake up at noon. This teenager's in heaven. The next day, they can't go to sleep until 7:30 in the morning. And they get to wake up there, and then you can see. So you march it around that way with the concept of it's always easier to stay awake longer. This is utter hell on parents. So during this time, the parent basically has to keep this schedule, because in this time you have to make sure that your teenager is not doing anything they're not supposed to be doing, not drinking caffeine, not napping, things like that around the other way. This is completely incompatible with school and things like that. Now that being said, this is a short program. Look at this. You can get there in about a week, and if you can do it and maintain it, it is the most effective. It's biologically, it works best with your biology. But the minute then you let that kid go to a sleepover, go to prom, and they're up until 1 o'clock in the morning, you're back here. So there's a high relapse rate. But and I've had families do this where they boot camp their kids, you know, after summer vacations and things like that. But it's brutal. So it's not really a practical solution. We can't do that to the entire teenage world. So option B is to change our definition of what society wants. And the biggest thing with that is to align school systems with biologic rhythms. This has been recommended by the American Academy of Pediatrics, where they came out with a huge statement last year that said high schools and middle schools should start no earlier than 8:30 in the morning. So for those of you who are reasonably close to high school graduation, I mean, I started high school at 7:15 in the morning. Who started before 8 o'clock? Yeah. So it's the majority. It's a big shift for a lot of high schools to go to a later start time. Initially, when that research first came out, people were like, well, if you have them go to school later, all they're going to do is stay up later and just wake up later. They're not going to get any more sleep. And what the research has really shown is that if we change school start times so that they start later and our teenagers, they go to sleep at actually the same time. They wake up later. So they gain an hour of sleep in the morning hours. And with that has come improved academic performance, improved behaviors, things like decreased number of detentions, decreased conflicts in hallways, things like that. Very measurably decreased car accident rates, especially in those early morning hours. I mean, there are less people dying from this. And they have less daytime sleepiness with less weekend binge sleep. So these were like really good things. The big pushbacks that we've gotten as sort of a field from it are it can't happen overnight, especially in big districts. You can't just change high school start times and expect it to cost nothing, have everybody follow those rules. The biggest pushback we get from across the country has really been from athletics. So high school athletics that basically say you're cutting into practice time and you're cutting into game time has been a huge barrier. In Seattle, just local advocacy stuff, we actually did this. So if you didn't hear, at the beginning of this academic year, Seattle high schools went from a varying start time to everybody starting at 8:45 in the morning. And that went for all the high schools and most of the middle schools. In order to keep it fiscally neutral, we had to move all the elementary schools to 7:40 or 7:55 in the morning, which, you know, didn't go over so well with a lot of elementary parents, but the reality is little kids get up early. And so they were up anyway, and so it seemed to make a whole lot of sense. And thus far, it's been okay. There's going to be a lot of data collection to come. Bellevue went to a system where their high schools now start at 8:30. Issaquah is likely going to a 9 a.m. start for high schools next year. Lake Washington School District is also going to be doing it. So it's basically affecting the entire area. Seattle has been probably the largest urban city to do so thus far, and the fact that it cost $0 to do so, other than my personal sweat, tears, and labor, has been, it's basically proof that a big city can do it. Prior to this, it's really been very upper class suburban areas that have done it. Minneapolis did it as well, and so they're the other really big city that's done it. So let's talk about, let's go back to our kid here who can't sleep. So let's talk about the fact that he can't sleep and thinks about how tired he's going to be. So that can't fall asleep part of it, or insomnia. So insomnia, it is the most common thing that brings in adults, and it's one of the most commonly prescribed medications in both adult medicine and pediatrics, is medications to help with sleep. There is a complete lack of understanding of insomnia by most primary care providers, and there's really not enough people who know about insomnia to treat it, especially in those who have developmental differences. The important thing to remember with insomnia is it's a state of total body hyperarousal. If you have insomnia, meaning if I give you the opportunity to fall asleep and you can't fall asleep, just what's wrong with that? I mean, like if you're sleeping 4 hours a night because you can't sleep, and then if I give you the chance to sleep, you can't fall asleep, your brain is going. It's going, it's going, it's going, it's going, it's going. And we know that people who suffer from chronic insomnia, if you look at their things like heart rate variabilities, their arousal thresholds, they will wake up to things like a pin dropping, a door closing, things that, I don't hear in my sleep because I'm pretty deep in sleep, and people with insomnia don't get into those deep levels of sleep. They maintain this communication with the environment around them, and that level of arousal is something that really drives their inability to fall asleep. It's a combination of 3 factors that leads to that sleepiness and then that decreased daytime functioning, but there's predisposing factors, perpetuating factors, and then precipitating factors. It's a fairly well-known model. And in teens who have delayed sleep phase, that frustration of repeated nightly failure becomes both precipitating and perpetuating. Now think about it in a pediatric condition or even a teenage condition, where if you have a mom who's trying to get their kid to go to sleep, their 16-year-old to go to sleep at 9 or 10 o'clock at night. I've now shown you the evidence that that teen is most likely really awake at 9 or 10 o'clock at night. And all that teen and all that mom do are fight, 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 fight. And then the next morning, the mom is dumping ice water on his bed, trying to drag him out of bed, yelling at him to go, 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 and all they do is fight. Incredibly negative experiences on a repeated daily basis when you have a teenager who can't sleep. I can't tell you how much, we have families in tears over this all the time. It's an incredible stressor. But if you were to start and end your day every day by fighting with your parents, how happy would you be? How happy would you be as a parent? And how happy would you be as that teen? So I just really want you guys to think about that. And then think about those where if they have developmental differences or intellectual disabilities, and maybe their bodies can't fall asleep the way that we think that they can. And that parental expectation is for you to go to sleep because, God, I've been taking care of you all day, and they can't. That level of stress is just astronomical. But it really shapes it's shaped by this basic tenet between parents and children, which is that if your child doesn't sleep, as a parent, you don't like your child as much. Doesn't mean that you don't love them. You don't like your child as much when they don't sleep. So just keep that in mind when we're talking about this repeated failure of being in bed and not being able to fall asleep, just how much that will just trickle up and trickle down. Insomnia is common in adolescents. Probably, and this is higher now, I think, with media usage, closer to 20%, I think, of our adolescents will suffer from insomnia at some point in time. Many of us are familiar with the risk factors for insomnia. Treatment for insomnia, I can't tout enough about education. So people will look at somebody with autism, with ADHD, with FASD, and say, behavioral interventions aren't going to work, this kid is off the wall. But it's so not true. Randomized control trial after randomized control trial in primarily ASDs, ADHD, anxiety, depression, chronic medical conditions, and chronic pain, if you treat the insomnia with behavioral interventions, they get better. They get better. It's just that people don't have the resources to do that behavioral treatment outside of a research setting as of right now. These research interventions are not long, and I've not listed them all out here because there's just too many of them, but they tend to be 2 to 3 hour courses for parents. That's it. It's not that long when you talk about a lifetime of medications. It's just that most people are so over the edge, and the wait to get into therapists and ABA is so long that by the time they come see me in clinic, like, they're ready to fall off a cliff. And they sort of need that short-term medication to at least just get everybody back from the edge and get into a point where they can actually listen to me. Sleep hygiene. So sleep schedule. Remember, the most important is consistent morning wake times. We want a cool, dark, quiet room with no electronics. Age-appropriate bedtimes, and that's something really important to remember. There are a lot of kids that I care for that have severe intellectual disabilities, whose parents expect their 16-year-old son, who might not be able to talk, to still go to sleep at 7 p.m. It's just not going to happen. I don't know any 16-year-olds that go to sleep at 7 p.m. And so regardless of intellectual state, that's something that, again, that physiology kicks in. If that kid has a post-pubertal body, it's unlikely he's going to be able to go to sleep at 7 p.m. Overall health, so regular exercise, particularly in the early morning and not right before bed. It's also common in kids who have ADHD. There's this perception that, well, if we run them really hard, they'll just crash. And the reality is it just winds the kids up more. It makes it harder for them to fall asleep. Physical exertion is definitely important, and it is much more effective early in the day when we talk about sleep-wake rhythms. You definitely want to avoid significant strenuous physical activity 2 hours within the time that you want to go to sleep, because it's known that that will delay your melatonin secretion. Stimulus control. So bed is for sleeping only. I'm a pediatrician, so I don't say the other thing, but in adult sleep medicine, they say beds are for sleep and sex only. I don't tell my kids that. But it's not for worrying, doing homework, watching TV, talking on the phone, or anything else like that. Bed is just for sleep. So that's stimulus control. If you want to do any of those other things, I'm not saying you can't, just don't do them in bed, do them elsewhere. So we really try to create little nooks, safe places for kids to go, ideally outside the bedroom, but if needed, even a simple corner in the bedroom where they do those things, and so that it's not in bed. Sleep restriction. And this is something that parents always look at me googly-eyed when I first say that. So the first thing, I try to put this in a framework, is I try to make this a successful adventure. So if you know that the kid or the teenager that you're working with tells you repeatedly, I can't fall asleep until 1 o'clock in the morning, let them go to sleep at 1 o'clock in the morning. Let them experience the success of being able to say, it's 12:45, I'm gonna brush my teeth, turn off the lights, go to bed, and actually fall asleep. Who would have thought? And that positive experience for that child does so much for the brain. I can't even tell you. I mean, it rewires that association from bedtime being a negative thing to a positive thing. So let them go to sleep when they have a chance of succeeding. And I really tell parents to back off. And parents look at me and say, we're paying money for this? But no, I tell them, back off, let them succeed at it. And then when they've established success at that bedtime, whether it be 1 o'clock in the morning or whenever, then you can start moving it forward a little bit, because that positive association is now present, where they're not going to look at the bed and immediately think, oh God, I'm going to get into bed and just fail at something. Now they're going to look at the bed and say, I'm going to go to bed and just go to sleep. And so we compress their sleep, we make them very efficient at sleep, and then we start to extend it first. So the first treatment for insomnia is not to go to bed earlier, which is where most parents will knee-jerk. Say, well, if it takes you 3 hours to fall asleep, I better put you to bed 4 hours before your bedtime, before that time, so that you can, but you know, we've all been there, where your parents say, well, you're really tired, or you have so much trouble waking up in the morning, you need to go to bed earlier. And that's just 1 extra hour that kid is there ramping themselves up, becoming more and more anxious about the fact that they're not sleeping. So it backfires pretty much all the time. The cognitive restructuring that goes into it is actually a much smaller component. So I find that stimulus control and sleep restriction are pretty much, they work in about 90% of kids, just the combination of those two, of just telling parents, let them succeed at it, and then we can rearrange their timing. But there are families who definitely need that cognitive restructuring, and the biggest one that I'm challenged with is TV and radio. So, and it's always the parents do it too, where they fall asleep with the TV on or the radio on. And I ask them why they need that, and they say, well, it just helps me to fall asleep sooner. And they can't really quantify why. And I just look at them and I say, so you're telling me that you would rather have a conversation with whatever is on TV, whatever character is on TV, whatever the DJ is saying, whatever lyrics are in that song, as opposed to just thinking about, with your own thoughts, just having a conversation with yourself. You'd opt for a conversation with the character on TV than with your own thoughts, because that's basically what's happening. And when you put it that way, all the parents just go, oh. And yeah, that's what it is that they would rather not think about the things that are on their mind. And so basically they use the characters on TV and they have a mental conversation with it. That's how TV and anything with lyrics draws you in. Is you become part of that show. You become, maybe just as a passive observer, but you are engaged in that show in that way. So I really sit there and say, okay, well, let's talk about it. If you truly just need noise, there's white noise machines. If you really need music, there's music without lyrics. Music that's boring in that sense. But TV, always. There is sound that comes with the TV, unless you have it on a channel that's just pure static, and nobody has that anymore. Another common miscognition is that I have to sleep with my smart mode, is my alarm. I mean, I've given people in clinic like $10 and go to Bartell's, just get an alarm clock, a little electronic one, and it doesn't have to be fancy, but you don't actually need your smartphone in there. For people who are really technologically driven, Echo Dots, wonderful little things. You can just say, Alexa, set the alarm, and it just talks back to you, and it does it, and there's no screen with it. It's fascinating. So, if people want to use the technology is there, but it doesn't have to be associated with a screen. So there you go, that cognitive restructuring. And then medications. There is no FDA-approved medication for sleep in anybody less than 16 years of age, period. That being said, it's one of the more common medications prescribed by pediatricians for children is sleep aids. Children are not little adults, and that includes teenagers, even if they look like an adult size. They have different metabolisms. They have quicker metabolisms. So for instance, Zolpidem or Ambien. Ambien comes in 5, 10 milligram tablets and then a 12.5 milligram controlled release one. Providers will say, well, you're a teenager, you're a kid or a small adult, let's give you the 5 milligram dose. What happens is that kid's metabolism is so quick, they rip through that 5 milligrams and they immediately start hallucinating. That 5 milligram dose was designed for a little old lady whose metabolism is slower than molasses, where it's going to last them forever. And really, that teenager probably needs the 10 milligram dose, if not even the 12.5 milligram dose, because their metabolisms are so much quicker, they need a higher dose of it if you really want to get them to sleep. So then you have this teenager who's in this state of purgatory and just hallucinating and not sleeping. And it's great because it's an awful situation. So you really need to be working with somebody who has a familiarity with pharmaceuticals in adolescent biology. The other thing is that circadian delay. So remember that you have a teenager who's most awake at 9 or 10 o'clock at night. That's probably when most parents want to give them a sleep medication. And that's when a sleep medication is least likely to be effective. So a lot of parents will say, here's some Benadryl, here's some melatonin, just take it, please go to sleep, 9 o'clock at night. And that kid is still wide awake. It's because that's when their body is most physiologically awake. It's just, there's too much of a gap between where their alertness state is and where we want a medication to get them to. And above all, it just doesn't treat the underlying problem. These are a list of medications that are out there that are used for insomnia. Most of them, all of them actually, are off-label for children. We have experience with some of them, like the alpha agonist clonidine type of thing in kids with ADHD or gabapentin in those who have seizures. So we have safety data, but not necessarily efficacy data when it comes to insomnia. And really, oops. Okay, well, what that little red square is supposed to show is that you need to hit this window of when their alertness starts to go down when you give that medication. Otherwise, it'll just backfire on you. Okay, let's talk about media use. It's the elephant in the room as everybody in clinic comes in who has their smartphones and they're looking at the smartphones instead of talking to me. So that whole media thing. I get asked this a lot with why is screen time so bad? And most people think, well, it's a time displacement thing. That's obvious. If you're looking at your phone, you're not sleeping. So there's the basic of that. And that's where most people sort of draw the line. They think, well, you know, if I just turn off my phone, I'm just gonna, like, it's like 3 minutes that I'm looking at my phone. That's not taking away from that much sleep. But the reality is it's the second two that are actually much more impactful. It's the psychologic and physiologic arousal from media content, particularly violent media content, and an effect of light on circadian rhythm and alertness. I'm going to talk about the light part of it the most because it's the most scientifically where we have the most data. So here's our melatonin curve again. Okay, so here we have a situation where they're in dim light, and you can see melatonin takes on that normal curve. Here we have them in bright light, but they're wearing very dark goggles, so blocking that light entry. And you can see that the melatonin is slightly lower, but it still follows that same curve. And then if they're in bright light, melatonin is completely squelched. It doesn't secrete at all. So just how much light is bright light? And you can see here, so where they're in dim light for a while, and then they have a light exposure to a variety of different lights, and then they're back in dim light. These two up here manage to secrete melatonin, and all of these are suppressed. I don't expect you to read that from afar, but so let me just tell you that. You can see where the ones which that the degree of light exposure actually suppresses melatonin. We basically, from this graph, know that it's those greater than 200 lux. So at greater than 200 lux, you can suppress your salivary melatonin in as short of 10 minutes of exposure, and that lasted for about 30 to 40 minutes before your melatonin started to surge again. Keep that in mind. Just what is 200 lux? It's not like people think in lux. I think in lux, but I don't expect most of you to think in lux. So here we have common light intensities. Oh, sorry. Here we have common light intensities with various conditions. Here we have where 200 lux is, and we know above 200 lux suppresses melatonin, and below it allows melatonin to secrete. An office or a setting like this is about this is a little dimmer, but like right up here is probably around 300 lux. A typical office is 300 lux. So if you're just working in your office, it's probably suppressing melatonin. If you are watching TV, it depends on the distance that you are from that TV. But funny enough, nobody actually watches TV anymore. They're all on their smartphones, and they're all on computers in bed right here. So it's probably upwards of greater than 300 lux. So we know that smartphones, computers in bed, things like that, likely emit enough lux to actually mess with your melatonin. And again, 10 minutes. I promise you, any teenager who gets on their phone is on it for longer than 10 minutes. They may think it's only like a few minutes, but it's way longer than that. So screens, we know, emit enough light. We don't know about dose dependence. We don't know about the role of selective blue light reduction. There was this big thing that came out that said, oh, if you get a blue light filter and things like that and screen it out, that it won't have that same effect on melatonin. That study, that series of studies has not been reproduced, and that study was actually funded by Apple. I'm just going to say that. And the other thing that we know is that this is synergistic with adolescent biology. What did I tell you before? Teenagers always will stay up later. If you're sticking a screen in front of their face, or if they're sticking a screen in front of their face and they're emitting all this light, they're gonna be awake longer and longer and longer and not feel sleepy. And it's not just a matter of shutting off the phone, but that alertness level, because their melatonin hasn't been secreted, will last much longer than whatever time they actually shut off their phone. 97% of adolescents in the US have at least one electronic item in their bedroom. These days it's usually smartphones. And school-age children in the US now spend at least 7 hours a day in front of a screen, and that includes computer time at school. It's really quite sad. I love this study. This is not a scientifically robust study in the sense that it was self-report, but I love it because it wasn't the US, because people think this is an American problem. It's not. It's an international problem. And it had just about 10,000 teenagers. And again, teenagers are more likely to be honest when it's an anonymous survey as opposed to their parents or to their providers. And so these data to me were just absolutely staggering. But what you can see here is hours of screen use and then sleep duration. And very simply, as more of their screen time went up, their sleep duration went down. And we have a fair number of children or teenagers rather, who are getting less than 6 hours of sleep. It completely correlates with screen time. 6 hours of sleep. That means from midnight to 6 a.m. I can tell you from a sleep medicine perspective, that little test where you fall asleep quickly during the day, you would flunk that test if you got 6 hours of sleep for more than 1 or 2 nights in a row. You'd fall asleep at the wheel. Use of electronic devices during the last hour before bedtime. It's, again, nearly ubiquitous. Girls are on their phones and boys are playing video games. What can I say? Daytime use is also high. Online stuff and then PC use for school is also a big contributor, which is a whole nother conversation in and of itself. What about media use in those who have developmental differences? And I'm going to pick on autism here for a second because I think the autism world has made leaps and bounds in those who have difficulty with communication and using media and screen devices to augment communication. And plenty of parents come in and tell me with their autistic children that if it were not for the iPad, that they would absolutely have no relief and no respite at all. And I, as a parent and a provider, I get that. I mean, these parents, some of these children are so very high demand and really high movement, that parents are looking for that respite and becomes that babysitter. But I do think we're sort of shooting ourselves in the foot a little bit. So this is a study that came out in 2013 that looked at media use amongst boys with ASD, ADHD, and then that were typically developing. And again, this was questionnaire only, so not quite as robust as we would like it to be in terms of lack of objective data. But if you look here, the average number of hours spent sleeping per night as a function of diagnosis group with access to a TV in the bedroom. And so those who did not have a TV in their room got close to an hour more sleep in every single category, including those with typically developing. But look at the difference in those with autism and ADHD. I mean, that's significant. We drug kids with autism all the time to try to get more sleep. And none of our medications work as effectively as just taking the TV out of the room. I promise you that. And this is a much harder graph to read, but basically the more video game hours they play a day, basically the average hours spent sleeping also go down. Again, not really rocket science in that sense, but very poorly quantified in those who have developmental differences. This study just came out looking at bedtime electronic use in children with autism spectrum disorder, and this study did include teenagers. And look at this, I feel like, gosh, for all the espousing that we try to do about getting TVs out of the room, half of these kids still had TVs in their room. I don't even know, there's just not a whole lot of excuse for it at this point in time. And more than half had TV as part of their bedtime routine. Again, this is kids with autism. And what this study has shown is that it's not so much the presence of just the TV in the room, it's whether or not the TV or any media was used as part of the bedtime routine. And that if screen time was used as part of the bedtime routine, i.e., okay, it's 7 p.m., bedtime's at 8 p.m., at 7 you get to start watching cartoons for 30, 45 minutes while mommy puts away the dishes and organizes your room and stuff like that, and then you brush your teeth and go to bed. Those kids had a much more challenging time in terms of length of time it takes to fall asleep. So in those where media was not part of the bedtime routine, it was a mean of 16 minutes, which is considered normal in a typically developing child, but 40 minutes in somebody who had media in their routine. If any of you are awake for 40 minutes prior to falling asleep, you know that's aggravating. People want to be efficient, and you feel like, gosh, why can't I sleep? Why can't I sleep? And that sense of anxiety just starts to ramp up. The other thing is media with violence versus without violence. What's violence? So there's lots of ways to quantify violence, but it ranges developmentally. And again, this is where you really need to know the developmental age of your child. Even if they have an 18-year-old body, they may function at a 4 or 5-year-old level. So who here has seen SpongeBob? Who's seen Caillou? Yeah, okay, so difference. SpongeBob to a little kid is violent. It moves at the graphic images and the pace at which that little thing moves around is unlike anything that occurs in the natural world. People don't talk like that. People don't move like that. They don't go bzz and like just show up at the other end. It's completely unnatural, and to a little child or to somebody with a developmental understanding of a little child, that is violent. And it might not involve guns and swords or anything else like that. I mean, that is just overt violence. That should never be part of the discussion. But just keep in mind that developmental understanding of what's normal and safe. Caillou, horribly boring, but is normal, is safe. He talks like this. And this is a pace that a 4-year-old understands. And it drives parents insane. It's the most boring show on earth. But that is what developmentally is appropriate for that age. I'm not trying to espouse Caillou, by the way. But just saying that that is considered safe in a 4-year-old's mind, and something like SpongeBob or any one of those that's just a lot more active movement is just completely graphically too much for them to incorporate in real time. And you'll notice that when this whole bedtime media with violence thing, that violence thing really, what happens is that they'll watch the super fast-paced show, they'll turn it off, and the kid will have a meltdown. And so the first thing that the parents do is turn it back on, because they don't want that meltdown to happen. But that meltdown is really as this child is trying to process all this information, and SpongeBob has long left the screen and they're still trying to figure out what happened. So that's really where that meltdown ensues. So remember that. So it's really not just media in the bedroom, which honestly there's just no excuse for having it there anymore, but it's also incorporating media as part of that bedtime routine. And a lot of parents, and particularly parents who have fewer resources, use media as a babysitter in those early evening hours. And it's something that really does go along socioeconomic lines. That's a whole nother lecture. Okay, so how do we fix this? Really, it comes down to parental modeling. You have to get the media out of the room altogether. Do a family charging station. I try to encourage media curfews of an hour or two prior to bedtime. The AAP, I think, just came out with an hour. 2 hours is where we would ideally like it, and it's just not realistic. Families are not going to follow unrealistic recommendations. You also just can't say that they shouldn't have any screen time, because the reality is they're going to. They're going to have screen time. So you can either work with them or just completely alienate them. But they will have screen time. And the things that I really try to say are, well, not in their bedroom, definitely not while they're in bed, and try to just separate it from the bedtime routine altogether. Don't make it as part of the bedtime routine. Don't say brush your teeth and then sit here and watch TV while I clean up the house, that kind of thing. What we need to work on as, I think, a society and culturally is that we need to come up with effective time replacement activities. We need to support our families a little bit better and give them things to do other than plant them in front of devices. And that means really giving our families more support. And that's just, again, a whole nother level of discussion. Educating parents, even when the kids are young, it's really important. And parents seem to get a kick of when their 6-month-old can look at the iPhone and touch little things and giggle. They think it's cute, and I just look at that, I'm just like, no, it's happening already. So education preemptively is really huge. And healthcare providers, we need to ask. We need to ask, I think we're so afraid when we walk into a room and there is a completely nonverbal, very poorly functioning teenager with, let's say, autism, who has never really been able to integrate into their family life or anything like that, whose caregivers are completely exhausted, who can only get through the clinic visit because they have the iPad on. We're too afraid to ask, so what do you do at nighttime? So are they just in front of that iPad all the time? And I suspect that they are, and I suspect when that iPad is taken away, just like the little 4-year-old who can't verbalize, but what happened to SpongeBob? That autistic kid just ends up having a complete meltdown. And so they are given the iPad back. And that's this whole vortex of, again, just because they have a developmental difference doesn't mean that we don't know what it means. But it doesn't mean that they don't respond to media and have the same maleffects from media that a typically developing kid may have. And there's lots of suggestions that they do. So we just need further research into that. We need to be further just very sensitive to those issues, I think. So anyway, that's all I have. So I'm happy to take any questions. Yes?
You never mentioned reading.
Yeah.
In bed.
So reading in bed is a mixed bag, but for those who have insomnia, it's not a good idea. I think for little kids who are read to in bed, where it's part of their bedtime routine, as long as it's a very short process, it's probably just fine, and it actually can be an incredibly lovely experience. But for people who suffer from insomnia, reading in bed becomes, again, a perfect excuse to do anything but fall asleep. And so I really try to draw a very firm line that you're not doing anything in bed, and if you want to read prior to bedtime, it's very easy to set up a chair somewhere in the bedroom to do it. Kids love beanbag chairs and things like that, so I have lots of patients who will incorporate reading prior to bedtime as part of the routine, but I still ask that they don't do it in bed.
My granddaughter has ADHD, and she talks about not being able to turn her brain off.
Yep.
She knows that's the problem, and it's hard, how do you tell them?
Right.
You can't tell them.
You can't tell them, and
You have to figure out ways.
And a lot of it is our understanding or lack of understanding of just in the mind that has ADHD. Are they neurologically wired the same way? And so are they able to shut it off? I think that's actually a very good question to ask. I think there's some proof that even if they seem to have a hard time shutting it off, there are likely some interventions and behavioral modifications that we can do to help promote that shutting it down. But there are probably a fair amount of kids out there that still, despite those behavioral interventions, can't without the aid of medications.
She will read about insomnia in bed. When
She reads about insomnia in bed.
by Googling it, and why would she can't sleep?
Well, okay, so there's so many things wrong with that picture. No offense to your granddaughter, but get off Google, which means get off a screen. Don't read about insomnia. But
She wants information.
she wants information, but it's because she doesn't like to fail, is my guess. She hates getting into bed and not being able to sleep. And so I would encourage her to do that exploration, but out of bed. At least do it at a desk or a chair or just anywhere but bed. Yeah, that's a really hard one. Yes?
So as a college student, how would you, my roommate loves to sleep with the TV on, and I have to wear earplugs and an eye mask to prevent that, or because it bothers me, and she definitely is very oh, I need to have the TV on and anything. So are there any more tricks that I can use to kind of
So, do you guys share a room?
Yeah.
Have you seen those tent beds? It's a pop-up bed. It's actually the greatest thing that ever was Google it. But it's like a pop-up tent bed, and really what it does is it's basically a. Have you seen those pop-up hampers that they sort of wire up? And so this is a pop-up bed, and it basically creates this square above your bed that is opaque, and it's basically pitch black dark in there. Probably won't block sound, and you may still need earplugs for that, but frankly, I would put that on her and say, get yourself some wireless earphones or something. It's not fair to me, and I would put that on her, but if you can't, earplug it, and then this pop-up bed is something that you can literally zip up. You're not going to suffocate in it or anything like that. There's ventilation, but it provides a completely dark enclosure to a bed in a shared room. So you can do that. I think coming up with makeshift, IKEA is my other favorite place, and just makeshift curtains and things like that you can even drape around a bed, sort of like the old-fashioned bathtub. You can do that with bed curtains and stuff like that that are fairly inexpensive. But yeah, creating a dark environment for yourself that's opaque is going to be key. I don't think eye masks work that well because they tend to slip off and people don't like that sensation. But like I said, I would put it on her to get wireless earphones because you shouldn't have to sleep with earplugs in your ears. But look at the pop-up beds. Anything else? Yes.
I see lots of research coming out. Is the word really spreading? Because I feel like a lot of people do not know this. About sleep and the problems that are associated with not getting enough sleep, especially for children.
I don't know. I think it's still a really, I think people are beginning to be a little bit more aware, and I think that the charge by school districts has been helpful. When you have a panel of people, for instance, in Seattle Public Schools saying, you know what, your child's sleep is important enough to us that we are going to completely turn our school system upside down to do it. That was a big deal. But there is still a very much so cultural perception that sleep is a luxury and not a necessity in this country, that if you have work to do, you work first before sleep. Sleep is for those who are weak, and people who are high functioning and successful in life often tout about how they are not, they don't need as much sleep as like the other person. Donald, you know who I'm talking about, but you know, like things like that. I think people, sadly, you know, good and bad, Arianna Huffington in the HuffPost, she loves talking about sleep, and she put out a book, The Sleep Revolution, earlier this year. And while not a medical book, the fact that there are at least people who are prominent in media who actually will embrace it and talk about it has been helpful. So I do think that the word is getting out, but there is still particularly a top-down effect when it comes to people at the top tout not sleeping. And that is something that from a leadership standpoint we need to change. Thank you very much.